everybody. Welcome to our presentation. We are the Zone Group. My name is Amanda Schaffler, and I'm from Tacoma, Washington.
Hi, I'm Caroline Jones, and I'm in San Francisco, California.
Hi there, I'm Jocelyn Lenz, and I'm in Sacramento.
The title of our presentation is The Effects of Video Self-Evaluation on Skill Acquisition with Yoga Postures. Yoga is a form of mind-body fitness with ancient roots and a rich history of practice around the world. The practice of yoga has become an increasingly popular practice in Western culture. In a study by Woodyard 2011, they studied therapeutic effects of yoga on a wide range of health conditions, including anxiety, depression, heart disease, cancer, dementia, multiple sclerosis, and many others. Yoga is officially recognized by the National Institute of Health as a form of holistic medicine. With the increase of widespread use of yoga as a therapeutic tool, practicing is an important consideration. A study by Swain and McGuinn in 2016 studied yoga injuries over a 14-year period of time, 2001 to 2014. They found approximately 25,590 yoga-related injuries were documented in emergency departments. And among these, individuals ages 65 or older were at the highest risk for injury. Who practice yoga do so in classes with many people, or at home, either on their own or by watching instructional videos online. Both methods involve a limited availability of instructor feedback to assess accuracy of poses. Video self-evaluation is an intervention that has been used to improve performance and teach correct methods of performing a variety of tasks. A study by Belfiore, Fritz, and Herman in 2008 assessed the effectiveness of video self-monitoring on the accuracy of delivering discrete trial instruction to students with autism. They conducted a multiple baseline study across staff, using 4 staff as subject participants. Staff were taught how to use video evaluation to score themselves in correctly performing 5 steps of discrete trial instruction. Results looked at the 3 steps of the DTI that had the highest levels of inaccuracy during the baseline phase. For these 3 steps, participants improved accuracy by 75%, 15%, and 30%. The results of the study found participants improved the accuracy of their DTI steps during the intervention phase. The original study by Downs et al. Studied the effects of video self-evaluation on the accuracy of yoga poses. This study consisted of 2 participants who were college-age men with no yoga experience prior to the study. Results showed that video self-evaluation significantly increased the percentage of correct steps for 5 of the 6 poses across the 2 participants. Results for the first participant showed significant improvement in the video feedback phase, but only modest video self-evaluation phase. Results for the second participant showed significant improvement in accuracy of poses in both the video self-evaluation and video feedback phases.
In the field of research and practice, replication is important to ensure believability of a particular study or findings. In 1968, Bear, Wolf, and Risley wrote that replication believability. The process of replication includes repeating the changes and manipulations to the independent variable, which were conducted in the previous study in order to gain the same or similar outcomes. This shows that there was not likely a variable other than the independent variable for the change in the dependent variable, and also demonstrates the reliability of the change. The purpose of our study was to replicate the previous study, which assessed video evaluation as a method of increasing the accuracy of 3 common yoga poses. Participants included 3 students from Ball State University enrolled in master's program. Amanda had minimal yoga injuries. Caroline also had minimal prior experience with yoga and no current injury, and had minimal prior experience with no current injuries as well. Each of the participants conducted the study in their own homes 2 times a week in order to incorporate video self-evaluation and task analysis for increased accuracy of the targeted yoga behaviors. The materials included included the use of digital recording devices, laptops, and phone cameras to record each yoga pose during a session. Yoga mats were also used for the study, except for the first baseline session. YouTube channels were used to upload and review the videos of each participant's sessions and poses, and Google Docs was utilized to create and share the task analyses.
Behavior for this study were 3 common yoga poses: facing dog, warrior 2, and tree pose. Target behavior for this study was completing all steps for these 3 poses correctly with 100% accuracy following intervention. Examples include, while on a yoga mat, participant moves their body into an inverted V shape to mimic a downward dog yoga pose and holds it for a period of 30 seconds. Non-examples include, while sitting at a desk, participant reaches both arms into the air to stretch for a period of 4 seconds or less. Here's an example of the task analysis for the downward dog pose, for the warrior 2 pose, and for the tree pose.
Data was collected through permanent product recording to track the accuracy of each yoga pose. Participants watched each video session and used the task analysis for each pose to score accuracy. Steps in the task analysis were either marked correct or incorrect according to the criteria described in each step of the task analysis. Steps was divided by the total number of steps for each pose, resulting in a percentage.
During the baseline phases, participants viewed a series of 3 videos demonstrating the position for downward dog, warrior 2, and tree poses. The videos were agreed upon by the participants prior to starting baseline. Videos were chosen from YouTube due to the web page's ease and accessibility for all 3 participants. Each video was no longer than 1 minute in duration. These videos served as the role of the researcher instructor used in the original study. Participants completed all 3 poses twice each week during baseline. Steps of the baseline phase included: 1. Each participant viewed the yoga instruction video on YouTube. Step 2. Each participant started recording as they attempted to complete the pose after watching the video. Step 3. Participant attempted to hold the pose for 30 seconds. Step 4. Participant stopped recording. Step 5. Each participant uploaded the video to their personal YouTube channel and shared it with the group. Step 6. Using a task analysis, each participant scored the correct steps for another participant, acting as a researcher in the original study. During the treatment phase, participants incorporated video self-evaluation and task analysis to increase accuracy of the targeted behavior, which were the yoga poses. During treatment, participants viewed the task analyses for each yoga pose, then attempted to replicate the pose according to the steps outlined in the task analysis. Treatment was introduced at varying phases for each participant as noted in the multiple baseline design. As in the baseline phase, participants completed each set of poses twice per week. Steps of the video self-evaluation intervention phase. Step 1, each participant started recording as they attempted to complete the pose from the task analysis. Step 2, participant attempted to hold the pose for 30 seconds. Step 3, participant stopped recording. Step 4, each participant uploaded their video to their YouTube channel and shared it with the group. 5, using a task analysis, each participant scored themselves on the correct steps for the pose they just performed. Step 6, the scored task analysis for each pose was then uploaded to Google Docs so that IOA can be calculated. And here are some visual examples of Caroline during baseline for downward dog. This was using the YouTube video guide, and Caroline following treatment, which was the implementation of the task analysis on session 14. And here's Warrior 2, baseline prior to the task analysis, and Caroline treatment session 14. And tree pose, baseline and tree pose following intervention and treatment.
IOA was calculated by using YouTube and Google Docs. Each participant scored 30% of the task analyses of the other 2 participants throughout the length of the study. In order to be counted as correct, all poses must have been held for a minimum of 30 seconds. The percentage of agreement for each task analysis was calculated by dividing the number of agreed upon steps by the number of total steps in the task analysis, and then converting the result to a percentage. After scoring, each task analysis was shared on Google Docs with the group, and IOA was calculated. For Amanda, the average IOA across behaviors was 67% for baseline and 96% for intervention. For Caroline, the average IOA agreement across behaviors was 72% for baseline and increased to 96.3% for intervention phase. And for Jocelyn, the average IOA across behaviors was 76.3% for baseline and 97.3% for intervention. We did an IOA recalibration after session 6.
Due to the fact that participants in our study also functioned as researchers and observers, treatment integrity data was assessed using the IOA data. Treatment integrity data was collected for 30% of the poses throughout the study. For the first 6 sessions, percentage agreement between participant and researcher averaged 70%, with a range of 57% to 83%. After session 6, we conducted a retraining of participants in how to score the task analysis. The retraining consisted of all 3 participants watching a randomly selected video of a session for each pose and talking through the task analysis for that pose together. Examples and non-examples were discussed for each step of the task analysis for all 3 poses. After the observer retraining, agreement between observers increased to an average of 91.4%, with a range of 75% to 100% agreement. According to Montrose-Wolf, social validity in behavior analysis can be evaluated in 3 ways: assessing the social significance of the target behavior, assessing the appropriateness of the procedures, and by assessing the social importance of the results. Due to the limitations of our study, we were unable to use certified yoga instructors to assess the appropriateness of our procedures, as was done in the original study. We evaluated social validity by researching current literature on yoga poses and yoga-related injuries. We assessed the social significance of the target behavior by researching the popularity and benefits of yoga practice. We found that yoga is a widespread practice that is increasing in popularity. As stated in the literature review, it is now recognized by the NIH as a form of holistic medicine. The social importance of the results was also assessed in the literature review. We found that a high number of yoga injuries occur each year, highlighting the importance of accurate yoga poses to minimize injury. As yoga continues to be practiced widespread and is used more frequently to treat a broad range of health conditions, the social significance of accurate yoga poses is assessed to be highly relevant to all who practice yoga. Results. These are the results for Amanda, myself. For downward dog, I had a baseline average of 48% and an intervention average of 84%. For the Warrior 2 pose, I had a baseline average of 45.8% and an intervention average of 85.1%. And for the tree pose, I had a baseline average of 62.5% and an intervention average of 97.7%. So while there is a significant increase in accuracy of correct yoga poses for all three poses, a functional relationship cannot be determined due to the fact that for the poses of downward dog and tree pose, a stable baseline was not achieved before introducing the intervention.
Results for Caroline are shown in Figure 2. Because a stable baseline was not established for downward dog and tree pose, it is not possible to determine a functional relationship. However, after video self-evaluation was introduced, the data stabilized, showing an upward trend on both poses. For Warrior 2, the percentage correct increased substantially following implementation of video self-evaluation. My baseline average for downward dog was 60.5, and it increased after treatment to 89.3. My baseline average for Warrior 2 pose was 61.4, and it increased after treatment to 83.6. For tree pose, baseline started at 64.1 and ended after treatment at 97%.
For Jocelyn, for my own results, the introduction of the video self-evaluation resulted in a stabilized increase in the percentage of correct steps for all three of the poses. Due to baseline data being unstable for both Warrior and downward dog, the introduction of video self-evaluation resulted in a stabilization as well as an increased percentage for both poses. The tree pose for Jocelyn, for myself, was stable throughout baseline, although much higher than the other two poses in percentage. The introduction of video self-evaluation resulted in a maximum percentage gain. However, due to restrictions of time, this may not be seen over extended sessions. The introduction of video self-evaluation depicts some functional relation due to the increased percentage of correct steps. However, further data points would need to be acquired to ensure the stability. My average for Warrior baseline average was 66.5% and treatment average was 85.1%. For downward dog, the baseline average was 75.8% and treatment average was 95.4%. And for tree pose, the baseline average was 76.4% and the treatment average was 100%, but with only 2 sessions of data. The findings of our replication study show that video self-evaluation may lead to some increases in performance. All 3 participants showed substantial increase in accuracy of poses following the intervention phase. However, project limitations prevented participants from being able to definitively show a functional relationship. The ease of the video recording procedures while practicing the poses do allow for possible future replications with the suggestions and limitations that we outlined below.
We noticed several limitations as we completed our replication study. First, acting as researchers for one another during baseline exposed us to the treatment phase prior to implementation of that phase. This may have contributed to some of our baseline data trending upward as we were able to review the steps in the task analysis. Second, the original study did not include the task analysis used by participants. As a result, we wrote our own using resources we found online. We realized that our original task analysis was not written in explicit terms and was causing some confusion among participants. We redefined the task analysis to include more detailed descriptions. Had the original study provided the task analysis used, we would have been able to ensure that we were following the exact same protocol as the participants in the original study. Third, practice effects may have influenced our baseline data and cannot be entirely ruled out. Lastly, some participants introduced treatment phase before baseline data had stabilized. Therefore, a functional relation cannot be established in these cases.
Future recommendations are to include a singular task analysis for each potential pose or behavior, which has been verified by a certified yoga instructor. This will ensure that replication is accurate as per the task analysis. Another recommendation would be to include yoga instructional videos, which can be accessed by future replications in order to reduce drift in pose representation expectations among the researchers. Due to the variance in yoga practices, each pose may be represented differently among instructors, and as such, the value of one video and task analysis for replication of each behavior or yoga pose may reduce the variations and ensure more stability. And here's a list of our references.